In this presentation, we will review the image analysis of the finger and thumb. We will review the image analysis guidelines, common positioning errors, and how to identify them, and ways to take corrective action. Image analysis guidelines for the PA projection of digits 2 through 5 state that the soft tissue width and mid-shaft concavity should be equal on both sides of the phalange. There is no soft tissue overlap from the adjacent digits. The interphalangeal and the metacarpal phalangeal joints should be demonstrated as open. The phalanges should be seen without foreshortening. The pip joint should be centered at the center of the exposure field. And the finger and half of the metacarpal are included within the exposure field. Now, this may be protocol dependent as far as how much of the digit you must image or include within the exposure field. Here's those image analysis guidelines for your review. So let's talk about a couple positioning errors with the digits. When speaking of digits 2 through 5, and looking at rotation and how to determine that, you first want to look at the soft tissue on each side of the phalanx there. If the soft tissue is not symmetric on both sides, you're not in a PA projection. Typically, you are going to encounter external rotation rather than internal rotation of digits 2 through 5. That is because digits 2 through 5, the thumb prevents any internal finger rotation. So when you look at this first image here of rotation of the second digit, when the anterior surface of the digit is rotated towards the thumb, okay, digit 1, then the finger can be identified as in external rotation. Next positioning error we want to discuss that is commonly seen is the poor alignment of the joint space and the central ray. When we know that image evaluation criteria states that the IP and the MCP joints are to be demonstrated as open, and so when the finger is flexed or tilted towards the IR, the central ray will be poorly aligned with the joint spaces and the phalanges. This causes the phalanges to be foreshortened and superpose joint spaces and closing them. And as you can see in the projection to the right, that our distal phalanx are foreshortened and the joint spaces are closed here. In order to correct this, we really need to extend that finger so we can adequately image this digit. We are at our first practice analysis of the finger. Please review the image and answer the following question. Let's conduct this first practice analysis together. First, you want to take a look and make sure that we have not clipped any anatomic structures that we need, and we have the soft tissue of the finger. We have all of the anatomic structures down to the first half of the metacarpal bone. So next, we want to determine whether or not this is a true PA projection. And how do we do that? Well, we're going to look at the soft tissue of each side of the finger, and the concavity should be symmetric. And in this case, the concavity of the mid shaft is not symmetric. The finger is actually an external rotation. So in order to correct this imaging, we need to internally rotate the finger so that it is flat against the IR in a true PA projection. Go ahead and review this finger practice analysis and then answer the following question. Let's review this PA projection together. And looking at this image, we wanted to determine, do we have all our anatomic structures that are required? We have from the distal phalanx to the mid-metacarpal bone here on this digit. However, is the anatomic structures represented appropriately? And I would go with no. Do we see the interphalangeal joint spaces or the metacarpal phalangeal joint spaces demonstrated as open? No, we do not. Also, the distal phalanx distal and middle phalanx are foreshortened. This should indicate to you that the finger is flexed. In order to correct this imaging, we need to make a repeat image and extend that finger so it's placed flat against the IR. If the patient is unable to extend the finger, there are times that you can reposition the hand to an AP projection, aligning that phalanx of interest parallel with the IR, or you can align the joint space perpendicular to the IR if this is necessary. But typically you can use tape to help get that finger more in a PA projection. Let's move on to the PA oblique projections, digits 2 through 5. Image analysis guidelines for the PA oblique projection, digits 2 through 5, state that twice as much soft tissue width is demonstrated on one side of the phalange as on the other, and that typically is on the side facing the thumb because we take the projection on external rotation. More concavity is seen on one aspect of the phalangeal midshafts than the other. There is no overlap from the adjacent fingers. The IP and MCP joints are demonstrated as open. The phalanges are not foreshortened. The PIP joint is at the center of the exposure field. And the finger and half of the metacarpal are to be included within the exposure field. Here are those image analysis guidelines for your review. So let's talk about common positioning errors. Typically, rotation and adjacent finger overlap occurs in oblique projections. So we should really make sure that the adjacent fingers are free of superimposing the figure of interest. The other is insufficient and or excessive finger rotation. How do we determine when it's insufficient or excessive? In insufficient finger rotation, the soft tissue width on both sides of the digit will be closer to equal. If that is the case, then you are insufficiently rotated and we need to increase that finger rotation externally. In excessive, the soft tissue width on one side will be twice as much as that on the other side. And therefore, you're in excessive rotation. We need to bring that obliquity down some, more to that 45 degrees to adequately get that PA oblique projection. Go ahead and take a minute to analyze this image and then answer the following question. So let's analyze this image together. First, you want to check and see, do I have all the anatomic structures required for the imaging? And yes, you have, from the distal phalanx to the mid-metacarpal area for this projection. Next, we want to determine, am I sufficiently positioned? And so in looking at that, we're going to first look at the soft tissue width on each side of this digit. And in my opinion, the width is nearly the same, okay? So that should indicate to you that we are insufficiently rotated. The next thing we want to look for is, are our joint spaces open? And in this case, they are closed. The interphalangeal joint and the metacarpophalangeal joint is closed. We need to correct this imaging by increasing that finger obliquity to 45 degrees and extend that digit so that we can open up those joint spaces. Let's move on to the lateral finger projection, digits 2 through 5. Image analysis guidelines for the lateral finger projection digits 2 through 5 state that there should be no overlap of the adjacent fingers. The anterior surface of the middle and proximal phalanges demonstrate mid-shaft concavity, and the posterior surfaces should show slight convexity. More than twice as much soft tissue width is demonstrated on the anterior surface than the posterior surface. We want open IP joints. The phalanges should not be foreshortened. And your pip joint should be at the center of the exposure field. The entire finger, from the distal phalanx to the metacarpal head, are to be included within the exposure field. Here are those guidelines for your review. So let's talk about positioning errors that occur on the lateral projection. Failing to properly rotate the finger to obtain a lateral projection usually results in an image that looks more like a PA projection, where the soft tissue width on each side of the digit is more equal. And so typically this is an insufficient finger rotation. You'll have to realign the digit so that it is in a true lateral projection. Also, a few other things you can look at are the condyles on the phalange. They should be more superimposed on a true lateral projection. A second common positioning error is when the unaffected fingers are superimposing the digit of interest. If the hand is not drawn into a tight fist, or the unaffected fingers taped down and away from the anatomy of interest, the unaffected fingers will superimpose the proximal phalanx of the affected finger, preventing adequate visualization of that digit. So it is important that we get that unaffected, or that affected finger that we are looking at, away from the other digits. Take a few minutes and review this lateral finger practice analysis and answer the following question. So let's conduct this practice analysis together. First, you want to determine whether or not you have the anatomy of interest on the image. And we do. We have from the distal phalanx to the mid-metacarpal. Next, you want to determine is the adjacent fingers superimposing the anatomy of interest, and for the most part it is not. Next, we want to determine whether or not we are adequately positioned. And in this case, we are not. We are insufficiently rotated. You can determine this by looking at the middle and the proximal mid-shafts of the phalange. When the concavity is demonstrated on both sides, you are not in adequate rotation for the projection. Also, I like to look at the condyles in the middle phalanx there. They aren't close to superimpose, which indicates to me there is some rotation. In order to correct this image, we need to increase the degree of finger rotation until the finger is in a true lateral projection. Let's move on to the image analysis of the thumb, or first digit. Let's start with the AP projection. Image analysis guidelines for the AP projection of the first digit state that the concavity on both sides of the phalange and metacarpal midshafts is equal. There is equal soft tissue width on each side of the phalange. The IP, the MCP, and the CM joints are all demonstrated as open spaces. The phalanges should not be foreshortened. Superimposition of the medial palm soft tissue over the proximal first metacarpal and carpometacarpal joint is minimal. The MCP joint should be demonstrated at the center of the exposure field. The phalanges, metacarpal, and carpometacarpal joints are included within the exposure field. Here are those guidelines for your review. One last important structure that should be included in the exposure field is the trapezium. If that is not in your image, you have clipped vital anatomy and we must repeat the imaging. So let's talk about some positioning errors. In insufficient rotation of the thumb, this will demonstrate the medial palmar surface of the soft tissue of it, superimposing the metacarpals, okay? And when this occurs, if that medial surface is not drawn away from that thumb, that soft tissue and possibly the fourth and fifth metacarpals superimpose the proximal first metacarpal and carpal metacarpal joint. So we really need to increase that rotation to get that true AP projection and that palmar surface away from those joint spaces. The second positioning error is excessive internal rotation. When the arm and the thumb is internally rotated more than it needs to be for the AP projection, the anterior thumb surface and the greater phalangeal midshaft concavity is demonstrated on the side of the thumb positioned next to the hand on the projection. That is how you determine excessive rotation, by looking at that midshaft concavity and its location or position next to the hand. One more Positioning error that occurs with the AP projection is when we don't align the collimator with the long axis of the anatomy. Aligning the long axis of the thumb and the collimator's longitudinal light line enables you to collimate tightly without clipping the distal phalanx and while including the trapezium. So you want to make sure that you don't clip the anatomy of interest. In this case, you can always turn the collimated field of view to align with the long axis of the anatomy and or position the patient efficiently to align with the long axis of the anatomy and the IR. Please review this practice analysis and answer the following question. So let's conduct this practice analysis together of the first digit. When looking at this AP practice analysis, I want to look to see if I have all my anatomic structures. I do see the distal phalanx to the metacarpals, but is my anatomy demonstrated in accordance with evaluation criteria? And I am going to say no. The reason being is that the palmar surface is superimposing the proximal first metacarpal and carpometacarpal joints. Secondly, if you look a little bit more closely at the phalangeal concavity on the side of the thumb nearest the hand, it shows you that there is slight over rotation internally. So in order to correct this imaging errors in this image, we need to first correct the over rotation, okay, and make sure that the thumb stays in a true AP projection while utilizing the other hand to draw the palmar surface away from the thumb so we can adequately visualize the carpometacarpal joint and including the trapezium. You also want to make sure to avoid getting the patient's other hand within the collimated field. So let's move on to the lateral projection of the first digit. Image analysis guidelines for the lateral projection state that the anterior proximal phalanx and the MC demonstrate mid-shaft concavity, and the posterior proximal phalanx and the metacarpal demonstrate slight convexity. When visualized, the thumbnail is demonstrated in profile. The IP, the MCP, and the carpometacarpal joints are demonstrated as open. The phalanges are not foreshortened. The first proximal metacarpal is only slightly superimposed by the second proximal metacarpal. The metacarpophalangeal joint is at the center of the exposure field. The phalange, metacarpal, and carpometacarpal joints are all to be included within the exposure field. Here's those image analysis guidelines for your review. So let's talk about some positioning errors and how they can occur. In insufficient hand flexion, if the hand isn't flexed enough to position the thumb in a true lateral projection, you'll notice that the concavity on both sides of the mid shafts of the proximal phalanx and metacarpal are equal. This indicates that you're more in a PA oblique position rather than in that lateral projection that we want. You can also utilize looking at the condyles of the phalanges or the phalanx themselves. If they're not superimposed, you know you're not in a true lateral projection. In excessive hand flexion, where we're overflexing the hand, this causes the second proximal metacarpal to superimpose the first proximal metacarpal. This also can cause the thumb to rotate past that true lateral position we want and towards more of an AP oblique projection. Review this practice analysis and then answer the following question. So let's conduct this image analysis together. First, we want to determine whether we have all our anatomic structures. And in this case, we have from the distal phalanx to the trapezium in the image here. However, we want to determine whether we are adequately positioned or not. The first thing I want to look at is the mid shafts of the proximal phalanx and the metacarpal. And when you look at them closely, you can see that there's bilateral concavity on both sides, which indicates that we are insufficiently flexed with the hand. We need to increase that hand flexion so that the finger or the first digit is in that true lateral projection. The condyles here should be more superimposed with that proximal phalanx. Lastly, let's move on to the PA oblique projection of the first digit. Image analysis guidelines for the PA oblique projection of the first digit states that twice as much soft tissue is present on the side of the thumb next to the fingers than the opposite side. More proximal phalangeal and metacarpal mid-shaft concavity is present on the side of the thumb next to the fingers than the other side. Interphalangeal, the metacarpal phalangeal, and the carpometaphalangeal joint spaces should be demonstrated as open. The phalanges should not be foreshortened. The metacarpal phalangeal joint is at the center of the exposure field. The phalanges, metacarpals, and carpometacarpal joint are all included within the exposure field. Here are those image analysis guidelines for your review. Common positioning errors for the PA oblique first digit typically include excessive obliquity and hand flexion. In excessive obliquity, the projection tends to look more like a lateral first digit projection rather than an oblique projection. In this case, the condyles of that proximal phalanx will be superimposed. The mid-shaft concavity on the anterior side will be prominent, where on the posterior side it is not. And so in this case, we need to decrease that obliquity so that we can get to that 45-degree PA oblique thumb projection. With hand flexion, this tends to close the joint spaces and foreshorten the phalanges here. So we need to make sure that the thumb is extended appropriately and aligned with the central ray so that our joint spaces are adequately visualized. Please review this practice analysis and complete the next question. conduct this practice analysis together. When looking at this image, I want to determine whether I have all my anatomic structures. I have my distal phalanx to the trapezium all included within the exposure field. However, for the PA oblique projection, we want to determine whether we're adequately positioned. First, I'm going to look at the degree of rotation. And when looking at that, we are in a true oblique projection. However, we need to look at the joint spaces. These joint spaces are not open. And so how does that happen? That occurs when the hand is flexed and not placed flat against the IR. So this causes foreshortening in the phalanx, the distal phalanx there, and it causes the joint spaces to be misaligned and closed on the projection. In order to correct this, you just want to reposition the palm and thumb so that it's flat against the IR and re-expose the image or the patient for repeat imaging. This concludes the image analysis of the thumb and finger. If there's any questions or concerns, please feel free to reach out.